Welcome back to AudioBoards. Today we're covering one of the most important and potentially life-threatening conditions you'll encounter in medicine, pulmonary embolism or PE. Our focus is practical management, how to recognize it, risk stratify it, treat it, and avoid common mistakes. We'll follow the modern approach reflected in recent AHA/ACC guidance and contemporary PE literature.
PE is one of those diagnoses that always feels high stakes.
It absolutely is. Pulmonary embolism is a clot that usually originates in the deep veins of the legs or pelvis, travels through the right side of the heart, and lodges in the pulmonary arteries. The consequences can range from mild symptoms all the way to obstructive shock and sudden death. One of the most important concepts to understand from the beginning is that PE is not a single disease. It exists on a spectrum ranging from low-risk PE to massive hemodynamically unstable PE, and management depends heavily on where a patient falls on that spectrum.
So when should we suspect PE?
The classic presentation includes sudden dyspnea, pleuritic chest pain, tachycardia, and hypoxia. However, PE is famous for being a great imitator and can present in many different ways. Patients may come in with shortness of breath, chest pain, syncope, hemoptysis, unexplained tachycardia, a new oxygen requirement, signs of a deep vein thrombosis, or even sudden hypotension and shock. Just as important as the symptoms are the risk factors: recent surgery, hospitalization, immobilization, active cancer, pregnancy, or the postpartum state, prior venous thromboembolism, obesity, estrogen therapy, and inherited thrombophilias should all increase your suspicion for PE.
So the diagnosis starts before ordering tests. It starts with recognizing the risk profile.
Exactly. PE is primarily a disease of probability. Before ordering anything, you should estimate the patient's pretest probability. The first step is determining clinical probability using validated tools such as the Wells score, the Revised Geneva score, or clinical gestalt. For patients with a low pretest probability, the pulmonary embolism rule-out criteria, or PERC, can help avoid unnecessary testing. If the patient does not satisfy PERC criteria, then a D-dimer should be obtained. For patients with an intermediate probability, D-dimer remains useful as a rule-out test. However, for patients with a high pretest probability, you should skip the D-dimer altogether and proceed directly to imaging.
And CT pulmonary angiography remains the primary imaging test?
Correct. CT pulmonary angiography, or CTPA, remains the diagnostic standard in most institutions. If CT cannot be performed, alternative studies such as a ventilation perfusion scan, compression ultrasonography for DVT, and echocardiography in unstable patients can all contribute to establishing the diagnosis. Once PE is diagnosed, the next step, and arguably the most important step, is risk stratification, because management decisions are driven far more by risk than by clot size alone. Historically, we use terms like massive PE, submassive PE, and low-risk PE. Modern guidelines still recognize these concepts but emphasize a more nuanced severity classification that incorporates hemodynamics, right ventricular function, biomarkers, and clinical severity scores. At the bedside, it's still useful to think of patients as high, intermediate, or low risk. High-risk PE includes patients with sustained hypotension, shock, cardiac arrest, or a need for vasopressors. Mortality is highest in this group, and these patients often require urgent escalation of therapy. Intermediate risk PE refers to patients who remain normotensive but have evidence of right ventricular dysfunction, elevated troponin levels, elevated BNP levels, or significant clot burden. Low-risk PE patients are hemodynamically stable, have no right ventricular dysfunction, no biomarker elevation, and low clinical severity scores. These patients generally do very well.
So treatment decisions are driven more by risk category than clot size alone?
Exactly. A large clot in a stable patient may actually be less concerning than a smaller clot causing right ventricular failure and shock. The patient's physiology matters more than the image. For unstable patients, management begins with the ABCs. Oxygen should be administered as needed, and hemodynamic support becomes critical. One important principle is to be cautious with fluids. The right ventricle is already struggling against increased pulmonary vascular resistance, and excessive fluid administration can worsen right ventricular dilation and decrease cardiac output. Small fluid boluses may be helpful in selected patients, but aggressive fluid resuscitation is generally avoided. If vasopressor support is required, norepinephrine is usually the preferred first-line agent in obstructive shock caused by PE. In cases of refractory shock, advanced therapies such as VAECMO and other forms of mechanical circulatory support may be considered at specialized centers. The cornerstone of PE management, however, is anticoagulation. Unless there is an absolute contraindication, anticoagulation should begin as soon as PE is diagnosed, or even strongly suspected when clinical probability is high. Several anticoagulant options are available. Unfractionated heparin is particularly useful when procedures may be needed, when thrombolysis is being considered, or when severe renal dysfunction is present. Low molecular weight heparin is often preferred in stable patients and in many patients with cancer-associated thrombosis. Direct oral anticoagulants, including apixaban, rivaroxaban, edoxaban, and dabigatran, have become increasingly important. Modern guidelines generally favor DOACs over warfarin in eligible patients because they are easier to administer and are associated with a lower bleeding risk.
So, for most stable patients, a DOAC ends up being the long term therapy.
Exactly. Now let's discuss one of the highest yield board topics in pulmonary embolism management, thrombolysis. Systemic thrombolysis should be strongly considered in patients with hemodynamically unstable PE, persistent hypotension, or obstructive shock. The most commonly used agent is alteplase. The major advantage is rapid clot dissolution and improvement in hemodynamics. The major downside, of course, is bleeding, particularly intracranial hemorrhage.
What about intermediate risk PE?
That's where things become more controversial. Routine thrombolysis is generally not recommended for all intermediate risk patients because the bleeding risk often outweighs the potential benefit. However, if a patient begins to deteriorate with worsening right ventricular failure, escalating oxygen requirements, or progressive hemodynamic compromise, then rescue thrombolysis may become appropriate. Over the last decade, we've also seen increasing use of catheter-based interventions. These include catheter-directed thrombolysis, which delivers lower-dose fibrinolytic therapy directly into the clot, and mechanical thrombectomy, which physically removes clot using catheter-based techniques. Potential candidates include patients with high-risk PE, selected patients with intermediate high-risk PE, patients with contraindications to systemic thrombolysis, and patients who fail anticoagulation alone. Decisions regarding these therapies are typically multidisciplinary and often involve a pulmonary embolism response team, or PERT.
So, not every patient with RV strain automatically needs thrombectomy?
Correct. Most patients improve with anticoagulation alone, and invasive therapies should be reserved for carefully selected cases. One major shift in modern PE management is the recognition that not every patient requires hospitalization. Many low-risk patients can be safely managed as outpatients. Candidates for outpatient treatment generally have stable vital signs, no right ventricular dysfunction, a low bleeding risk, reliable follow-up, and adequate social support. Tools such as the Pulmonary Embolism Severity Index, or PESI, and the Simplified PESI score can help identify appropriate candidates. This approach reduces unnecessary hospitalization while maintaining patient safety.
What about the duration of anticoagulation?
That's another board favorite. The duration depends largely on whether the PE was provoked or unprovoked and what ongoing risk factors are present. For provoked PE, such as PE associated with surgery, trauma, or temporary immobilization, the standard treatment duration is typically 3 months. For unprovoked PE, treatment usually lasts at least 3 to 6 months, and many patients ultimately require extended therapy. Patients with persistent risk factors, such as active cancer, antiphospholipid syndrome, or recurrent venous thromboembolism, often require indefinite anticoagulation if the bleeding risk remains acceptable.
So, the question isn't just how long can we treat, but rather how likely is it to recur if we stop?
Exactly right. Another aspect of care that's often overlooked is follow-up. Many clinicians focus on the acute event and forget that recovery continues long after discharge. Current recommendations emphasize early follow-up, ideally within about 1 week after discharge. This visit should focus on medication adherence, bleeding assessment, and symptom review. At approximately 3 months, clinicians should reassess the duration of anticoagulation and evaluate for persistent symptoms. Persistent dyspnea after PE should never be ignored because some patients develop chronic thromboembolic pulmonary disease or chronic thromboembolic pulmonary hypertension. These conditions can significantly affect quality of life but are potentially treatable if identified early. Let's finish with a few rapid-fire pearls. Always assess pretest probability before ordering tests. Remember that D-dimer is a rule-out test, not a rule-in test. Risk stratification determines treatment. Anticoagulation remains the foundation of therapy. Thrombolysis is primarily reserved for hemodynamically unstable PE. Most intermediate risk patients do not require routine thrombolysis. Catheter-based therapies should be considered only in carefully selected patients. Many low-risk patients can be safely treated as outpatients. Always determine whether a PE was provoked or unprovoked before deciding on anticoagulation duration. And finally, persistent dyspnea after PE should always trigger evaluation for chronic thromboembolic disease.
If I had to summarize PE management in one sentence, it would be this: diagnose quickly, stratify risk accurately, anticoagulate early, and escalate therapy only when the patient's risk profile justifies it.
Exactly. That's the essence of modern pulmonary embolism management. Thanks for listening to AudioBoards. Stay tuned for more educational content in our next episode. The views and opinions expressed on the AudioBoards podcast do not necessarily reflect those of our employers. This podcast is for educational purposes only and should not be used to diagnose or treat any medical conditions. It is not a substitute for professional medical advice. Always consult a qualified board-certified healthcare provider for any medical concern.